Hi, wondering what you're going to do October evenings now that you've binge watched everything? Well, the AAOA has a solution for you. We encourage you to join us for our live stream annual meeting. You get to stay in the comfort of your home and watch everything virtually, but this is really innovative and meant to be interactive. So watch here for a sneak preview of our clinical Pearl sessions and see what you think.
Hello, I'm Dr. Mark Mehle. I'm coming to you from Cleveland, Ohio. I'd like to talk a little bit for about 5 minutes on migraine and why it's important to our discussions in ENT. I have no relevant disclosures. We all see sinus headache patients, but what is sinus headache? Well, it turns out sinus headache is a patient complaint. We see this frequently. A couple large studies have looked at that complaint, and it turns out that the majority of times you're dealing with migraine. Eros' study was done in Phoenix, Arizona, 100 patients complaining of sinus headache. 86% of those had migraine or probable migraine. Kurt Schreiber did a much larger study looking at 3,000 patients with complaints of sinus headache. It turns out that in these patients, 88% of them had migraine or probable migraine. We'll define that shortly. But he also found they often had stuffy or drippy noses during the presentation of sinus headache. So often nasal congestion and dripping seem to be part of the presentation with that sinus headache complaint. Now, two reasons why this is hard to diagnose. One is that often it's mid-facial. Our physician colleagues are often drawn off the diagnosis by a mid-facial presentation of the pain as opposed to the forehead, for example. So V2 migraine presents to ENT doctors, and there's a parasympathetic, drippy, stuffy nose that happens along with the migraine process. So stuffy, drippy nose, mid-facial pressure often gets diagnosed as being a sinus problem instead of a migraine. So how do we find migraine? And the answer is we need to know the diagnostic criteria. I suggest that every ENT doctor be familiar with these. Migraine lasts between 4 and 72 hours. A lot of these people don't have auras, so if they don't have an aura, they need at least 5 episodes. But you need 2 of the main criteria. That's unilateral throbbing, moderate to severe, worse with movement. You need 2 of those 4. Doesn't have to be severe, doesn't have to be unilateral, just 2 of those 4. And then in addition to that, nausea, vomiting, or photophobia, phonophobia, so lights and sounds. So again, that completes the diagnosis when we're looking at the sinus headache population. Almost 90% of them will comply with these sort of criteria. Important to realize, though, the migraine doesn't exist in a vacuum. Often when we look at studies like Anita Jackson's study, looked at 100 people complaining of sinus headache, then often these patients have migraine, but often those migraines are accompanied by allergy or accompanied by sinusitis or both. So this is important to realize because migraine doesn't exist in a vacuum. If you don't ask those questions I just mentioned, you will not make the diagnosis. You're going to miss this. And the most important reason why is that the #1 symptom we're least likely to improve with endoscopic sinus surgery is sinus headache. So avoid disappointment. Find the migraineurs ahead of time. You can avoid unnecessary or ill-guided surgery and resolve these things medically in these patients where surgery itself may not play much of a role. So you have to look for this to find it. Finally, as far as treatment of the migraine patient, I would suggest that ENT doctors get familiar with this, just like we all use PPI therapies for LPR patients, for reflux patients. We should all get comfortable using migraine meds when we see the sinus headache presentation. I like sumatriptan, which is a triptan medication. Sumatriptan, the old trade name was Imitrex. I use 100 milligrams with these sinus headache presentations of migraine. Often you'll see very nice responses. Often it'll help confirm your diagnosis, and it needs to be part of your therapeutic armamentarium. Be aware there are good studies looking at nutritionals and anti-epileptic medications and beta blockers showing that we can actually prevent some of these headaches in many of our patients, and certainly neurology consultation is appropriate in many of them. Finally, remember that allergy and migraine are comorbid. They walk hand in hand genetically, therapeutically, even potentially. Chronic sinusitis also is more common in migraineurs and vice versa. We're not even sure why, but be aware. If you don't ask the migraine questions, you will miss the diagnosis, and you really don't want to be operating on the wrong patient. That's one of the key reasons why migraine questioning, at least in migraine therapy, should be part of your practice.
Now that you've had a chance to learn a little bit about migraine from Dr. Mehle, we hope you'll consider registering for the AAOA's annual meeting. It's free for AAOA members. The meeting will not only include pearls like Dr. Mehle's and several other hot topics. We're going to feature a day on biologics and what they mean for otolaryngology, a day on practice management topics, including E&M coding, telehealth, and office efficiencies, which has become more important post-COVID. During the weekdays, we're going to have a surgeon's lounge for each time zone, where we'll start on Monday in the East Coast time and migrate west. And that'll give you some unique perspective and opportunity to network and ask questions of our panels of experts. And in the evenings, we will feature some games on journal articles you may have missed, immunotherapy and the business of medicine, more clinical pearls like Dr. Mehle just offered, and we'll wrap the whole thing up with a nice panel on COVID and what it means going forward. We'll hope you'll consider joining us, and we look forward to having you in our audience. Thank you.